Welcome, and thank you for logging on for this School Nurse Professional Development online training. This topic is topic 2 in a 5-part series, and this training will cover mental health, depression, anxiety, and medications. Highmark Foundation, in collaboration with Penn State Hershey Pro Wellness Center, is pleased to offer this professional development opportunity for school nurses. Between fall of 2015 and fall of 2016, this collaborative effort will result in 5 online professional development trainings utilizing physician experts to address select topics identified by school nurses. The first training on dermatology is available now, and the second training in the series focuses on mental health, depression, and anxiety and medications. Future topics include diabetes, coming in March of 2016, asthma and allergies, coming in May of 2016, and food allergies, coming in October of 2016. Please note, the information provided in this web series should not be used during any medical emergency or for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Call 911 for all medical emergencies. Links to other sites are provided for information only. They do not constitute endorsements of those other sites. My name is Allison Lipsett-Simpson, and I am the Education Specialist for the Penn State Hershey Pro Wellness Center. Joining me is Dr. Lydia Petrovic-Dovat. Dr. Petrovic-Dovat is an Assistant Professor of Psychiatry at the Penn State College of Medicine. She is a Director of the Child and Adolescent Anxiety Disorder Program and the Associate Site Director for Child Services at Penn State Milton S Hershey Medical Center. She is involved in the clinical care as well as resident and medical student education. Dr. Petrovic-Dovat's clinical interests include association between allergies and internalizing disorders in children, and she actively collaborates with the Penn State Milton S Hershey Medical Center Department of Pediatrics at the clinical and research level. And we are so happy that she was able to join us for this webinar. So a little bit more information about the Penn State Hershey Pro Wellness Center. The center is committed to educating and inspiring youth and their families to eat well, engage in regular physical activity, and become champions for bringing healthy choices to life. We aim to be the trusted resource for educational programming, collaborative partnerships, and proven interventions in schools, communities, and like-minded organizations. In 2014, we worked with over 400 schools in some capacity, and we pride ourselves on being a great resource for schools and their partners. The PRO in our name stands for Prevention, Research, and Outreach. Examples of our work based on this acronym can be found on our website. Our website also has many resources, including the opportunity to sign up your school or community-based organization to be a healthy champion. Our Healthy Champions program includes free resources like event planning guides and promotional templates, customized school champion reports, future funding priorities, so you'll hear about funding opportunities first, and tools and resources to host and promote 4 annual events promoting healthy meals, healthy snacks, and outdoor play. These events include Apple Crunch, Go for the Greens, Move It Outside, and Walk to School Day. Annual registration is required and to receive your welcome kit at the beginning of each school year. Registration begins each spring, and there is no limit on how many schools or community-based organizations can enroll, but the welcome kits are limited, so log on to our website to read more details about this program. So again, I would like to thank Dr. Petrovic-Dovat for participating in this web series. We are so happy to have you with us and for you to share your expertise on this topic of mental health, depression, anxiety, and medications. So thank you.
Thank you. I'm very happy to be here. I'm Lydia Petrovic-Dovat, child and adolescent psychiatrist at the outpatient Penn State Hershey Medical Center. I'm going to talk today about diagnosis and treatment of depression and anxiety in children and adolescents. The first part of the talk, I will discuss evidence-based treatment for depression in children and adolescents, and the second part, we will review diagnosis, symptoms, and treatment of anxiety in children and adolescents. We will also discuss resources available for public. All medications should be considered off-label unless Food and Drug Administration approval is mentioned. This talk is only for educational purpose and should not be used as a treatment guidelines. Child who presents with symptoms of depression should be referred to behavioral health clinic for assessment. Child presents with symptoms of suicidal thoughts should be sent to emergency room for assessment. Children and adolescents with depression and anxiety can present to nurse's office in a school with number of complaints. Some of them come when they're feeling sad or referred by teacher who notice cuts, but some of them present with number of somatic complaints, headaches, stomach aches. They can also present with side effects of medications that could include range of side effects, but some of the most common ones are headaches, gastrointestinal symptoms, or even bruising. Prevalence of depression in children is 2%, and prevalence of depression in adolescents is around 6%. Children who have major depressive disorder can also have a number of other psychiatric disorders. 40 to 70% of them can have anxiety, eating disorder, substance disorder, or range of other psychiatric diagnoses. The course of treatment is separated into a few stages, but average duration of treatment is 7 to 9 months. 90% of children and adolescents with major depression receive remission within 2 years. Unfortunately, relapse rate is 50%. After 2 years, 40% can have recurrence of depression, and after 5 years, 7% of children can have recurrence of depression. Chronic course of major depression disorder happens in about 6 to 10% of children. A risk of recurrence includes if child has comorbid disorder, if they have been exposed to negative life events. There can also be family history of recurrent major depressive disorder, and some children develop bipolar illness. Bipolar illness is a separate disorder, but sometimes first episode can present as depression. So some of the children will develop bipolar disorder in their 20s or 30s. 20 to 40% of children who present with first episode of the major depression might convert to bipolar disorder. Children at risk include children who have family history of bipolar disorder who presented with psychosis. Pharmacologically induced mania is controversial, and at this time we do not think that all children who develop mania after start of antidepressants are going to develop bipolar disorder. Major depression can affect a number of areas in child life. It can affect academic performance, focus, concentration, and we can notice decline in grades. It affects the family life, and child sometimes stop doing things with the family they used to enjoy. They can also stop hanging out with their friends or stop doing sports and activities that they used to enjoy. Change in functioning is very important to monitor. Child with major depression can also have increased risk for suicide and also other psychiatric problems, substance abuse, or conduct problems. People develop major depressive disorder. There are a number of components that could affect this. It can be biological, genetic. Sometimes in a family there are more than one member with major depression, environment, stressful life events, or psychological reasons. Treatment is separating in few phases. Acute phase of major depression is 6 to 12 weeks, continuation treatment 6 to 12 months, and maintenance after 1 year. Treatment of major depressive disorder can be psychosocial treatments and also treatment with medications. Psychosocial treatments include cognitive behavior therapy, CBT, interpersonal therapy, psychodynamic psychotherapy, and group therapy. When child presents to the nurse's office, it is very important that we have complete list of medication the child is taking. Number of medications can cause mood cycling in children and adolescents. And the list you can see on this slide, but the most common is selective serotonin reuptake inhibitor that are used for treatment of depression and anxiety, can sometimes cause activation. Also, there are a number of other medications that are used, such as Effexor, Wellbutrin, tricyclic. Corticosteroid use can also present with sometimes increase in aggression or bipolar symptoms or depression. When choosing treatment for depression in children and adolescents, we need to consider severity and impairment. Which areas are impaired, and is this the mild or severe impairment? For major depression that presents as mild impairment, the recommendation is to start with psychotherapy. We start with medication and psychotherapy if the patient needs acute reduction of symptoms, if they did not respond to individual therapy first, or if they have comorbid disorder that requires treatment. We continue to monitor symptoms, but also continue to monitor functioning in a number of areas, including school and family, as well as social life. First line for treatment of major depression is selective serotonin reuptake inhibitor. These medications have FDA black box warning for potential increase in suicidality. In the study that was used when this was approved, 4% of children on this medication compared to 2% on placebo had increase in suicidal thoughts and gestures. At this time, we believe that treatment of depression is very needed and necessary. Those symptoms of suicidality should be monitored closely. But since the introduction of selective serotonin reuptake inhibitor, suicide rate had fallen steadily after the Second World War. At this time, because of the black box warning, some primary providers are very reluctant to prescribe those medications. We also changed some guidelines, so after we start this medication, we have a contact with the child much more often after start and continue to monitor closely. We have more than 20 placebo-controlled trials of antidepressants with more than 4,000 patients. There were no suicide in those studies. Selective serotonin reuptake inhibitor can also have a number of side effects. Activation can be present in 10 to 15% of children. Sometimes they present with increased energy, or they talk fast, or they cannot sleep. We do not think at this time that this is bipolar disorder, and not all of these children are going to develop bipolar disorder. At this time, from literature, we think that less than 1% of children have bipolar switch and that they develop later bipolar disorder. Some children present after treatment with selective serotonin reuptake inhibitor with loss of initiative, and we call it the frontal lobe syndrome. Some present with gastrointestinal symptoms or bruising. Selective serotonin reuptake inhibitor affect platelet function. So child who is in sports such as football can present with bruising. If child presents to the nursing office with bruising, it's very important that we check if they are taking some of the medication that could cause that. American Academy of Child and Adolescent Psychiatry has available online facts for families. They are available, and there is a number of different disorders that are described, including recommendation after some event happens in the country, such as shooting or natural disaster. It has recommendation how to talk to a child and what are the resources that could be used. It can be found online under Facts for Families under AACAP. In the Facts for Families, there is also description about symptoms that depressed child presents, and also literature that's recommended for patients and families. The symptoms they describe in Facts for Families include frequent sadness, tearfulness, crying, decreased interest in activities, hopelessness, persistent boredom, social isolation, low self-esteem, sensitivity to rejection, increase in irritability, difficulty with relationship, and number of other symptoms. Child with symptoms of depression should be assessed by behavioral health specialists and referred, and we continue to monitor change in eating, sleeping habits, withdrawal from friends, losing interest, decrease in activity, violent action, substance abuse. Some of the children also have changed in the way that they take care of themselves. We notice the change in personal appearance, or we notice personality change. Child with depression is at risk for suicide. And in fact, for family, there is also the area describing symptoms and what should parents look for, and also resources that are available. For review of that site, suicides are a very serious problem and is the third leading cause of death aged to 15 to 24-year-olds. And parents and also staff in the school should be aware of the symptoms if child is trying or thinking about hurting themselves. We can notice change in eating and sleeping habits. Sometimes child withdraws from family. Or we notice violent action in a child, running away, drug use, neglect, personal change. Some of the children do not tolerate praise or reward. Very often, child who is having those symptoms did present to provider, either pediatrician or psychiatrist within the last few weeks. Child and adolescent who is planning to commit suicide, sometimes presents with derogatory comments about themselves, saying they're a bad person, sometimes they are hopeless, or become suddenly cheerful at the moment when they make a decision that they're going to end their life. Some of them can have signs of psychosis, hallucinations, or bizarre thoughts. All threats to life should be taken seriously, in school or at home or in any other environment. Child needs help, and either 911 or they should be taken to emergency room and assessed by professional. Parents need to talk to their children about their concerns, and child needs assessment and treatment. Child who gets help can improve and heal and return to healthy path of development. How long do we treat depression? If child is doing well, responding to treatment, we consider decreasing medication after 8 months up to 1 year. We try with slow taper discontinuation, closely monitoring symptoms of depression. During that time, child should be seen by behavioral health specialists who will assess the symptoms and watch for signs of relapse. If there are signs of relapse, medications are restarted as well as individual therapy. As mentioned before, Facts for Families available by AACAP provide information as a public service and are free of charge for use by public. The next part of the talk, we are going to talk about anxiety disorders, symptoms, and treatment, evidence-based treatment. All medications should be considered off-label until FDA approval is mentioned. Pediatric anxiety disorders are very common. They're very secretive, and child can have a number of symptoms of anxiety without showing them in school. Sometimes the first symptoms that we notice are at home, where child can be increasingly irritable or angry. Grades are always, for a long time, very good. Anxiety disorders are common, but they are treatable. Prevalence in anxiety disorders in children and adolescents is 8 to 10%. When anxiety disorders are in severe range, they can affect every area of child life. We can see academic decline, psychosocial difficulties, but also it increases risk for suicide, depression, and substance abuse. In this slide, you see the prevalence of pediatric anxiety disorder, separation anxiety, social phobia, specific phobia, and panic disorder in children and adolescents. Child who have one anxiety disorder can also have another one, and more than 50% of them meet criteria for another anxiety disorder. Child who has anxiety disorder can have also other psychiatric disorders, but very common is depression. 8.2% of children who have anxiety also meet criteria for major depressive disorder. The question if anxiety is caused by nature or nurture is a very difficult one. We know that anxiety is part of human nature. It's normal, it's a survival mechanism, it helps us survive in the environment. Worrying, planning, being concerned about our job interview or new school and getting prepared is very beneficial. Sometimes we can have increased heart rate, breathing before we are preparing to do a certain activity. but it's not necessarily, these symptoms are not necessarily a need for treatment. Sometimes anxiety is caused by genetic or brain structure, or sometimes environment the child lives in or experiences. But there is also anxiety disorder that is more common in certain families. The question is, when should we treat anxiety? Anxiety can also be related to a number of medical conditions or medications. So some medication the child takes can present like increase in anxiety. It's very important that we have a complete list of medication the child is taking. Some of the disorders, like medical condition, can present more often with symptoms that look like anxiety, hyperthyroidism, metabolic abnormalities, arrhythmias. Also, some substances can look like child is suffering anxiety disorder, but it can be due to substance use. Anxiety-like symptoms can be caused by prescribed medication, number of over-the-counter medication, and also caffeine. Number of teenagers use many caffeinated drinks during the day, and that should always be checked. Some use alcohol or illicit drugs that can look like anxiety. Medical conditions that mimic mania as described, hyperthyroidism, head injury, temporal lobe epilepsy. Child should always be assessed completely before any diagnosis of depression or anxiety is made. Anxiety changes with developmental stages of the child. We know that brain develops and continues to develop frontal lobe way after teenager years. So anxiety and fears depend on child's stage and age. We're going to cover the age that when child is in school. So separation anxiety is most common at age 6 to 9. Child has difficulty separating from parents when they're dropped at the bus station or in front of the school. Some children have school avoidance, and getting them to school can be very difficult. Children aged 10 to 13 can have generalized anxiety disorder. Age 14 to 16, we have social anxiety. Child can have difficulty raising hand in a classroom, going to the parties, ordering in a restaurant. Working with the families in treatment and encouraging child to do activities they're trying to avoid is part of the treatment. Fears also change depending on the age of the child. Young children, age 6 to 9, have animal fears. Child, age 10 to 13, can have fear of death and danger. This is the age the child becomes aware that death is final, and it can present with much more difficult symptoms adjusting to the loss of the family member, the child who is 4 or 5 years old. Children who are afraid at night can be worried that somebody is going to come to their home. The parents notice they're waking up at night, going to their room. Children aged 14 and 16 have a fear of failure and criticism. There's a lot of talk about effect of media on children and how long should child be exposed to media, including, iPhones or TV or games during the day. And Pediatric Academy is coming with recommendations that are available online. It depends on child's age. At Facts for Family, American Academy of Child Psychiatry is also addressing media use, so please refer to that resource for current recommendation regarding that. Risk factors for anxiety disorder include parental anxiety, genetic vulnerability, and there is consistency in type of anxiety disorder in parent and the child. When we are assessing child for anxiety disorder, we interview the child and the parents, but we need information also from school, primary providers. How is child functioning? What are the concerning symptoms? We take detailed history, including developmental history and family history. We assess child functioning during treatment. How is child doing at home? Are they isolating in their room? Are they participating with family activities? How are they doing in school? Is there declining functioning? Is child able to participate in a class? How is child doing socially and with peers? Did they stop doing things that they used to enjoy, or they continue to participate in other activities? When assessing child for anxiety, we always ask about problems with the sleep. Sometimes child can have hard time falling asleep, and they spend maybe 1 to 2 hours in their bed thinking about what happened the day before, what's going to happen in the future. They're always very worried. They can awaken during the night many times, or parents start noticing they're coming to their room more often. Some of the children have headaches and stomach aches. Some children with school avoidance have those symptoms at Sunday evening or maybe Monday morning before the start of school, but not during the weekend or during breaks. Sometimes we notice eating problems. Child is not eating as well as they used to. Or they start avoiding social activities, parties, or sleepovers. Anxiety disorder can also look sometimes like inattentive type of ADHD, because child is suddenly having problem with the focus, with the concentration, with organization, remembering to do things, turning in the homework or assignments. They can also present with the need for reassurance. Even with all these symptoms, child with anxiety can still function very well in a number of areas. And school and grades can be very good for a very long time. American Academy of Child Psychiatry has also information about anxiety disorder available on their sites, free for use, from Facts for Families. There is a description of most common symptoms of anxiety, including constant thoughts and intense fears about safety of parent and caretaker, refusing to go to school, stomach aches, physical complaints, worries about sleeping away from home, being overly clingy, panic of tantrums, sometimes sleeping or nightmares. Symptoms of phobia can include extreme fear in specific situations like dog, insects, and fear causing significant distress. Social anxiety, fears of new situation, avoidance, not hanging out with the families. There is also resources and the end effect for families, for children and adolescents, as well as providers. When assessing child anxiety, including social anxiety and avoidance, it is very important that we are culturally sensitive. In certain cultures, children are not sent for sleepovers. They don't spend time away from home. So these should not be considered symptoms of anxiety, and we should be respectful of the family customs. Anxiety symptoms can cause distress, avoidance. Child can have a lot of fears and worries, and it interferes with child functioning, which is noticed in a number of areas. Also, some of the things that used to be easy for the child can start becoming time-consuming. Child spends a lot of time doing homework, rechecking their assignments, and sometimes doesn't go to bed on time and can be very tired in the morning. Also, waking up multiple times during the night can affect child functioning and energy during the day, as well as early morning awakening. In the psychiatrist's office, anxiety is assessed in a number of different ways. We interview the child, but also we use a number of screens which are age appropriate. Some of the most common ones is SCARED, Screen for Child Anxiety Related Disorder. This is the instrument that checks 5 areas of anxiety: school avoidance, separation anxiety, social anxiety, generalized anxiety, school avoidance, panic disorder. And there is a parent and child version. And this is free for use. Mask is the copyright protected, is also one of the common screens, as well as other screens discussed in this slide. We also use structured interview, number of self-report interviews, and parent rating, as well as behavior observation. For younger child, we use fear thermometer and other screens. Treatment for children and adolescents with non-obsessive compulsive anxiety disorder. Same with depression, we assess are symptoms in a mild, moderate, or severe range, and how are they affecting child's life. We consider severity and impairment before deciding about the treatment. Mild severity should be started with psychotherapy, and cognitive behavioral therapy is evidence-based for use of treatment of children. If we need acute symptom reduction, or patient did not have a response to individual therapy or had only partial response, or they have comorbid disorder, we also consider medications. We monitor functional impairment, not just anxiety symptoms reduction. For mild to moderate anxiety, psychosocial intervention should be tried prior to starting medications. Non-pharmacological interventions can be effective in children, and the most research is cognitive behavioral therapy. We also always have to consider medication because we do not want to leave seriously anxious children untreated in the case that their symptoms require that. Psychotherapy should be considered as a part of treatment even if child is taking medications. Cognitive behavioral therapy has different components. It includes psychoeducation, relaxation, when we are teaching child deep breathing, muscle relaxation, and a number of other techniques. Cognitive restructuring. Child with anxiety can present with a number of cognitive distortions about themselves and environment, and in therapy they learn to recognize them. Exposure, relapse prevention, and also child is learning coping strategies to deal when they have anxiety symptoms. Medications that we use for anxiety are similar medications that we use for major depression. So we have the same warning: black box, concerns for disinhibition, and also number of medications for children used for anxiety are not Food and Drug Administration approved for children. There are studies that support the treatment and they are used, but we always inform families and the patient if we do not have FDA warning or approval for use. First line for treatment of anxiety is selective serotonin reactive inhibitor. They're the first line. Many medications we use for children are not FDA approved. So I'm going to discuss some of the most common medications with their generic name and approval they have for children and adolescents. Fluoxetine has FDA approval for major depression and obsessive compulsive disorder. Sertraline has FDA approval for obsessive compulsive disorder. Paroxetine does not have FDA approval for use in children and adolescents, and citalopram does not have FDA approval. Escitalopram has FDA approval for major depression. Bupropion does not have approval, and fluvoxamine has approval for obsessive-compulsive disorders. New medications are also in the process of being approved. Just because patient is a medication that's not FDA approval does not mean that they cannot be on it, because we are using evidence-based treatments and studies that are available. But parents need to be aware if medication is or is not approved. Black box comes with use of SSRIs, but we know that psychiatric illness are often associated with suicidality. Suicide is the third leading cause of death among children aged 14 to 22 years. Here are the most common causes of death for children at different ages, and also for updated information, I need to refer you to AACAP site. So between age 5 to 9, the most common causes of death are accidents, unintentional injury, cancer, and developmental and genetic condition present at birth. In children 10 to 14, accidents, cancer, and suicide. Facts for Family at the AACAP has information about symptoms and resources. Child presenting with those symptoms of suicide should be assessed immediately by professional or in emergency room. 15 to 20-year-old, accidents, suicide, and homicide are the most common causes of death. We need to keep communication with child often open, assessed in the professional's office, but also in school and at home. Child needs to be able to communicate and disclose their concern to adults in their life. We also, when we assess children, need to have a safety plan that child can go to in a case that there are concerns that they have suicide thoughts. They also need to have numbers they can call. But child with active suicidal ideation should be assessed same day. So treatment for anxiety disorders, the first is, as I mentioned, selective serotonin reuptake inhibitor. We often see use of benzodiazepines in children, and they are sometimes used with children with panic disorder. And initially we have positive studies on clonazepam, but several double-blind studies controlled did not confirm efficacy of benzodiazepine in use for generalized anxiety disorders. The cyclic medication also do not have efficacy data. Antihistamine studies were not able to differentiate after initial support for the use of anxiolytic effects of antihistamines, and although they're sometimes used still and they're available over the counter, we do not have evidence to support their use in generalized anxiety disorder. In fact, there is medication approved for use in adult generalized anxiety disorder, but not for children at this time. Some studies are supporting use of Effexor. So, practical points for the treatment. Selective serotonin reactive inhibitors work very well. We do not have data on benzodiazepines, or they're very limited for use in generalized anxiety disorder. There's some data on augmentation strategies that we add one medication to SSRI. A typical antidepressants should be second line, not first line in use of treatment for children. We do not have data on effect of Buspar or bupropion. Cognitive behavior therapy is effective only when it's done by professionals trained in doing cognitive behavior therapy. Pharmacological treatment for anxiety and cognitive behavior therapy are complementary and should be used together. Side effects of selective serotonin reactive inhibitor can include activation in 10 to 15%, as mentioned in the beginning of the talk, bipolar switch, less than 1%, frontal lobe syndrome, gastrointestinal symptoms, and bruising because of effect of platelet, the selective serotonin reactive inhibitors can have. How long do we need to treat anxiety disorders? Long-term treatment has not been studied. If child is doing well, we consider tapering during the low stress time. We usually want child to be stable on medication for about 1 year. If child has relapse of symptoms, we restart medication. The child needs to be followed after discontinuation of medication by professional who can assess if there is a relapse of symptoms. AACAP guidelines are also available online, and they're the excellent resource for patients, families, and schools. We are going to discuss for a few minutes the changes that have been made in the new Diagnostic and Statistical Manual of Mental Disorder, 5th edition. Until recently, we have been using DSM-4, and at this time, we in psychiatrists use DSM-5 when diagnosing the psychiatric disorder. The major changes in diagnosis of depression and depressive disorder is that they made number of updates and changes. There is introduction of 2 new disorders, disruptive mood restriction disorder and premenstrual dysphoric disorder. Dysthymia as diagnosis is gone and is replaced by persistent depressive disorder. The new condition includes both chronic major depressive disorder and the previous dysthymic disorder. There has also been some changes in diagnosis of anxiety disorder. Obsessive compulsive disorder and post-traumatic stress disorder is not anymore considered part of anxiety disorders. So this is the biggest change. Changes in agoraphobia, specific phobia, and social anxiety includes that the largest change is that person no longer has to recognize that their anxiety is excessive or unreasonable in order to receive one of these diagnoses. The reason we are mentioning DSM criteria is because when we are sending the reports to school for individualized educational plan, we will no longer describe 5 axes that we used to describe in DSM-5. So to review, at this time, we discussed symptoms of major depressive disorder in this talk. We discussed importance of assessing child for safety, giving child resources that they can call and use in a case that there is crisis, and importance of sending child to emergency room if they have symptoms of depression or anxiety. We also discussed the medication that can cause or mimic symptoms of depression and anxiety, and importance of having always complete list of medication the child is on. We discussed pediatric anxiety disorder and differences between ages and importance in having developmental stage of the child in mind when assessing symptoms. Symptoms that would be considered appropriate and normal in 5- and 8-year-old could be concerning in a 15-year-old. It's also very important to know that not all area of functioning in anxiety disorder can be affected at the same time, and the child can still present in school as functioning, having good grades, but when we interview parents, child can have number of concerning symptoms that should be followed. We also discussed resources, and one of the free available resources is American Academy of Child and Adolescent Psychiatry, Facts for Families. It has alphabetical and numerical list of disorders. You can print that and use for free, unless it's used for any profit. And as any disturbing thing happen in the country, including shooting or natural disaster, this can be a very good resource because it gives you information how to talk to child and how to address those concerns, but also give you symptoms, a list of publications that would be very helpful. So if the child presents to your office, to nurse's office, with any of the concerning symptoms, it's very important to refer them for assessment to behavioral health specialty in the area or for safety assessment if needed, and to make sure to follow up to make sure the child is receiving treatment they need. Thank you.
Dr. Petrovic-Dovat, thank you for lending your expertise on this topic of mental health, depression, anxiety, and medications. As a reminder to our audience, this is the second training in the 5-part series. The first training on dermatology is available now, and the next training following this one will launch on the site in March of 2016. All of the trainings are listed up on the screen here, and again, diabetes will be coming in March of 2016, asthma and allergies in May of 2016, and food allergies in October of 2016. So Dr. Petrovic-Dovat, thank you again for lending your expertise, and thank you to our listeners for participating on this online training. If you have any questions regarding the training or any future trainings, please contact the Pro Wellness Center. Our email is on the screen. Thank you again. And to follow up, this training will close with a series of 4 sources slides from the presenter.